I'm Dr. Rowsan Masud. Would like to present echocardiographic evaluation of pulmonary hypertension. This is based on European Society of Cardiology and European Respiratory Society 2022. Pulmonary hypertension is second most important parameter after ejection fraction. Globally, 1% population are suffering from pulmonary hypertension. ESC class and recommendation and level of evidence. Key question on definition and diagnosis of pulmonary hypertension. Should a new hemodynamic definition of pulmonary hypertension? Should new echocardiographic probability of pulmonary hypertension approaches be proposed in symptomatic patient with a suspicion of pulmonary hypertension? Should screening be offered to guide detection of pulmonary arterial hypertension in systemic sclerosis? This is hemodynamic definition of pulmonary hypertension. Pulmonary hypertension mean pulmonary arterial pressure is more than 22 millimeter of mercury. This is a big change. Cutoff value has been reduced. Previously it was 25 millimeter of mercury, and now cutoff value is 20 millimeter of mercury. Precapillary pulmonary hypertension, mean pulmonary pressure 20, pulmonary waist pressure less than 15, PVR 2 Woods, isolated post capillary pulmonary hypertension, mean pulmonary artery 20, pulmonary artery waist pressure 15, PVR less than 2, combined post and precapillary pulmonary hypertension, mean pulmonary artery pressure more than 20, pulmonary artery waist pressure 15, PVR 2. This is new including in guideline exercise pulmonary hypertension, mean pulmonary artery pressure divided by cardiac output slope between rest and exercise. This is a clinical classification of pulmonary hypertension. Group 1, pulmonary arterial hypertension, idiopathic non-responder at vasoreactivity testing, acute responder at vasoreactivity testing, heritable, associated with drugs and toxin, associated with connective tissue disorder, HIV, portal hypertension, congenital heart disease, schistosomiasis, pulmonary arterial hypertension with feature of venous capillary involvement, persistent hypertension of the newborn. Group 2 is associated with left heart disease, heart failure with preserved ejection fraction, with reduced or mildly reduced ejection fraction, valvular heart disease, congenital acquired cardiovascular condition leading to post-capillary PAs. Group 3 associated with lung disease and hypoxia, obstructive lung disease or emphysema, restrictive lung disease. Lung disease with mixed restrictive or obstructive pattern, hypoventilation syndrome, hypoxia without lung disease, that is high altitude development lung disorder. Group 4 associated with pulmonary arterial obstruction, chronic thromboembolic pulmonary hypertension, other pulmonary arterial obstruction. Group 5, unclear or multifactorial mechanism, hematological disorder, systemic metabolic disorder, chronic renal failure with or without hemodialysis, pulmonary tumor, thrombotic microangiopathy, fibrosing mediastinitis. This is normal right heart pressure. Symptom and sign of pulmonary hypertension: dyspnea, fatigue, palpitation, hemoptysis, weight gain, syncope. Rare symptom due to pulmonary artery dilatation: exertional chest pain, hoarseness of voice, shortness of breath, wheezing, cough, lower respiratory tract infection. Sign, central or peripheral cyanosis or mixed, accentuated second heart sound, RV third heart sound, systolic or diastolic murmur. Sign of right heart failure, engorged or pulsatile jugular vein, distended abdomen, hepatomegaly, ascites, and peripheral edema. Other sign towards underlying cause of pulmonary hypertension, skip this. Transthoracic echocardiographic evaluation of pulmonary hypertension. I hope you will love this picture, and you will be able to diagnose pulmonary hypertension by this echocardiographic view. This is parasternal long axis view, enlarged RV, apical 4-chamber view showing dilated RARV, and basal RV-LV ratio more than 1, flattening of interventricular septum leading to D-shaped, decreased LV centricity index, dilated IVC, RVOT acceleration time less than 105, reduced right ventricular fractional area changes less than 35, reduced TAPC, we know TAPC normal level is 18, decrease asystolic time by tissue Doppler less than 9.5, RA area more than 18 centimeter square, TR velocity more than 2.8, and estimated of systolic pulmonary artery pressure, TR pressure gradient plus estimated right atrial pressure, and the presence of pericardial effusion is a poor prognosis of pulmonary hypertension. Echocardiographic probability of pulmonary hypertension and recommendation for further assessment if right peak tricuspid regurgitation velocity is less than 2.8, PH probability is low, alternative diagnosis 2.9 to 3.4, PH probability is intermediate, so echo follow-up, and if it is 3.4, PH probability is high, and further intervention or right heart catheterization. Additional echocardiographic signs suggestive of pulmonary hypertension. Already I mentioned RVLB basal diameter more than 1, flattening of interventricular septum, RVOT less than 105, early diastolic, pulmonary regurgitation velocity 2.2, pulmonary artery diameter 2.25 millimeter, IVC more than 21, RA area 18 centimeter square, TAPC by asystolic ratio is less than 0.5 millimeter of mercury. New diagnostic algorithm, unexplained dyspnea or suspicion of pulmonary hypertension. Skip this. This is comprehensive risk assessment of pulmonary hypertension. Determinants of this is for stator risk assessment. I am skipping all the hemodynamic measurement obtained during right heart catheterization. This is tricuspid regurgitation. If it is severe, it is triangular in shape, and if it is mild to moderate, it will be parabolic in nature. So already I have mentioned everything. This is the picture. We can calculate mean pulmonary arterial pressure by acceleration time. We can also measurement from pulmonary regurgitation. Thank you for patient sharing.